Muy buenas noches a todos. Bienvenidos a nuestra acostumbrada sesión mensual del Colegio Mexicano de Otología, Neurotología y Cirugía de Base de Cráneo. Esta noche tenemos el gusto de reiniciar con nuestros invitados extranjeros. Será una noche muy interesante, tanto por el invitado como por el tema propiamente que vamos a abordar, y asimismo por las personalidades que nos acompañarán durante la discusión de preguntas y respuestas. Bienvenidos todos y le pido a la doctora Mónica Rodríguez que nos haga favor de presentar a nuestro invitado de esta noche.
Hola, buenas noches. Hoy 5 de octubre del 2023, me da muchísimo gusto empezar con este tema. Que bueno, qué decir, ¿no? Hace unos 40 años empezábamos con implantes cocleares y ahorita estamos empezando con terapia génica. Entonces el cambio y la velocidad de todo lo que podemos hacer con personas con hipoacusia, pues es más que interesante, es novedoso y pues nuestra pasión, ¿no? Por eso estamos en estos colegios y aprendiendo cada día. El doctor Tward es director científico de ACOS, cuenta con más de 15 años de experiencia en otología y neurotología, es cirujano, pero también es científico y pionero en la aplicación de tecnologías de secuenciación genética moderna para problemas de salud críticos en biomedicina. El doctor se desempeña como profesor asociado en UCSF, que es la Universidad de California en San Francisco, y es cofundador de Affinia Therapeutics. El doctor Tward es autor de más de 40 publicaciones en el área de genómica, de biología del cáncer, biología de células madres y cirugía de base de cráneo. Recibió un doctorado en ciencias biomédicas y un doctorado también en medicina por UCSF y completó su residencia en otorrinolaringología y cirugía de cabeza y cuello para después hacer la subespecialidad de otología, neurotología y cirugía de base de cráneo en la Facultad de Medicina en Harvard. Tiene también un postdoctorado por MIT y por Harvard. Y nos da muchísimo gusto que esté con nosotros el día de hoy en este webinar y pues estamos deseosos de conocer en dónde estamos parados en este momento. Thanks for attending our invitation.
Okay, well, thank you so much for the kind invitation and the overly generous introduction. It's really a great pleasure for me to be able to speak with this group and with my colleagues from the Mexican Society here. So I wanted to talk with you today about some exciting work that we have going on at a company that I'm working with called Akuos regarding gene therapy for hearing loss. And I think it's an extremely exciting era for us because I think for so many of us, we've sat in front of our patients for a long time, year after year, and having them ask us, what do you have to help me? And we can say, well, we've got hearing aids and we've got cochlear implants and a variety of other techniques. But then they ask us things like, well, do you have any drugs to make our hearing better? No. Do you have what about gene therapy? Not yet. What about stem cells? And I think the progress has been very slow, but I think recently there's been a big inflection point with regards to the options that we are going to have. And we are just on the very earliest cusp of having really an explosion of new options for our patients that have sensorineural hearing loss. And so I think it's an extremely exciting time. So I'm going to share my screen here. Terrific. So I'm going to be talking today about work that has been done at this company, Akuos. We were recently purchased by another company called Eli Lilly, and we are now a wholly owned subsidiary of Eli Lilly. And so I have some disclosures here. I am an employee of Akuos. I also was a co-founder of Affinia Therapeutics and an equity holder in Insulin, but so you can take anything I say with that in mind. And then this is a standard disclaimer that comes from Lilly. I will be making forward-looking statements. This is for a legal requirement in the United States. So As we are all well aware, the way that hearing works generally is that sound comes into the ear, hits the eardrum, vibrates the eardrum. The vibrations are carried via these three little ear bones to this hollowed out space in the bone, the inner ear, where the vibrations are converted into electrical signals by the hair cells within the inner ear, and the signal is then transmitted along the cochlear nerve back to the brain. Now, a couple of things that I would like to mention briefly about the inner ear that make it unusual, and this should be familiar to most of you. The first thing to say is that the inner ear is essentially completely formed at birth. And the cells of the inner ear are the cells that you are born with. And as far as we can tell, we don't see any evidence of turnover of those cells, meaning the cells that are in there are the ones that you're born with, new ones are not created. And as a consequence, that has some importance in terms of the way that we think about developing drugs for the inner ear. A second thing to mention is that the otic capsule bone, which surrounds the inner ear, is the hardest bone in the body and has very, very low levels of turnover compared to other bone in the body. And it's so hard and dense, in fact, that people who've done sequencing studies of Neanderthals and ancient DNA tend to look for the otic capsule bone in order to isolate the DNA from there, because it's so dense, the DNA is preserved even for very ancient things. As we all know, you can have either a conductive hearing loss or a sensorineural hearing loss or a mixed hearing loss of the two. Today, I'm primarily going to be talking about sensorineural hearing loss. As we all know, we have a variety of decent options for things to help with conductive hearing losses. And for our sensorineural hearing losses, I will talk a little bit more about them momentarily. Now, if we zoom in to the inner ear and take a look at the structures of the cochlea, what we can see here in this scanning electron micrograph is the basilar membrane here, and the basilar membrane is coiled up like a snail shell, and lined along the surface of the basilar membrane, we have our inner hair cells and our outer hair cells. So there's one row of inner hair cells and 1, 2, 3 rows of outer hair cells. Everything that we will ever hear comes from a total of about 3,500 inner hair cells that are within our each ear. And I always found this to be quite amazing, that only 3,500 cells in the inner ear are responsible for a lifetime of hearing, and they're the same 3,500 cells that we are born with. One point that I would like to make here, as we all know, the outer hair cells are not responsible for transmitting sound signals back to the brainstem. They exist primarily function in amplification. If you lose your outer hair cells, you tend to get about a 60 decibel hearing loss, but you can still hear through your inner hair cells primarily. One thing that's important to remember, though, is that the outer hair cells are amongst the most sensitive cells within the inner ear. And as a consequence, as we age or in response to virtually any insult that occurs in the inner ear, the outer hair cells tend to get lost first. And so we can think of the outer hair cells as being a little bit of an indicator of the general health of the cochlea. And because we can use things like otoacoustic emissions to probe the function of outer hair cells, in later parts of the talk, I will talk about using otoacoustic emissions as a proxy, essentially, of knowing that the cells that we care about are still present in the inner ear and that the structures of the inner ear are generally preserved. I will also mention that all of us, starting at age 10, start losing our hair cells, and by the time we're age 85, we will probably have lost most of our hair cells and have a concomitant hearing loss that's associated with it. Based upon studies that have been done in human temporal bones, a lot of studies done in particular at Mass Eye and Ear, as well as elsewhere, have correlated audiograms that exist during life with the loss of hair cells or pathology within the inner ear. And we know that pure tone averages don't start to really drop until you've lost about 70% of your hair cells. So that's very interesting because it means that we are robust to loss of many cells, And what that also implies on the flip side is that your hearing can be probably pretty good if you had 25% of the hair cells being functional in the inner ear. And so this corresponds to if you had, say, about 700 or 800 functioning inner hair cells, you would probably have halfway decent hearing in the ear. And I'll ask you to keep that in mind for later. Now, as mentioned before, we do have a number of options for children and adults that can help with hearing. We're all familiar, of course, with hearing aids, and we're all familiar, of course, with cochlear implants as options. And both of these are excellent options that provide very, very clear benefit. But in both cases, they are far from perfect options. And in addition, we have a number of other options. Obviously, we have the listening strategies that we all think about and FM systems, which can be extremely helpful associated with lip reading as well. But once again, although all of these are very, very helpful, I think we would all agree that there is considerable room for improvement here. In particular, amongst patients that have severe to profound sensorineural hearing loss, although cochlear implants can be very good at restoring some of the clarity of sound and things like speech recognition, for more complex tasks for more complex tasks like hearing in noise or listening to music, cochlear implants are still not very good. An additional issue with cochlear implants is that over the course of the past 25 years, they haven't gotten hugely better than they were before. And it's unclear if this is because we are reaching the limits of the technology or if there are just some ideas out there that we are simply missing. But people have really tried many, many different strategies with cochlear implants to try to make massive improvements in there. And besides the continuous interleaved strategy that was introduced by Blake Wilson maybe about 25 years ago, we haven't seen a massive jump in terms of performance in the cochlear implants, although many of us, myself included, are continuing to work hard on finding ways that we can see if we can do much better for our patients. So I have here, I ran a cochlear implant hackathon in my lab at UCSF, which was intended to try to find better algorithms for cochlear implant hearing. And I'm not going to talk about that today, but I do have here a simulation based upon a neural-based vocoder of what cochlear implant hearing may well be like. So that's a simulation of what you might hear through a cochlear implant. Oh, sorry, did you hear the sound?
No, it didn't.
Oh, I apologize. Let me see. Maybe there might be a problem with the way that this is set up. That's okay. I'll skip over this part. I apologize. But let me try once again. Tell me if you hear this.
No.
No? Okay. I'm so sorry. I apologize. But
so in the future, can we click in the link that's below? Maybe.
Yes, if you click on the link that's below, it has these sound samples, and it's worthwhile looking at that website also because it was interesting. This was a collaboration that I had with the University of Minnesota as well as Advanced Bionics. But if you click on the link below, you can hear the samples of the sounds that I have here. And I think it gives a nice impression of what a cochlear implant might sound like for people that have hearing without hearing loss. And what I emphasize is that it's most certainly better than not having hearing, but it's far from normal hearing. Sorry. So getting briefly, for this crowd, this will all be familiar, of course. We know that one of the main ways that we can test for hearing loss, in particular in children, is using auditory brainstem response. And this is fairly typical of what we might see with an ABR, where we present sound at varying levels of presentation and look for essentially the threshold at which we start seeing the characteristic waveform of the auditory brainstem response. This ABR happens to be from some mouse studies that we've done. And the point that I wanted to make here is that having the auditory brainstem response is extremely helpful when trying to develop drugs for hearing loss, because we can do the same type of assay on mice or non-human primates or rats or gerbils, and we can assess the hearing directly of animals in order to see if drugs that we are testing are able to restore hearing. In this way, we can translate things between the mice and humans. One thing that we can't do in animals, so obviously we can also do behavioral audiometry. When we think about behavioral audiometry, this obviously we can't do on small babies, but we can do as we get older. But in some of the clinical trials that I'm going to be telling you about, we're going to be using ABR as a primary outcome measure because of some issues that you have with pure tone average, particularly in young children, as well as in children that have auditory neuropathy. Finally, otoacoustic emissions, as you're all familiar with, we play a sound into the ear, and as long as there's no conductive hearing loss, you get distortion products created by the function of the outer hair cells, and then you can record the sound that comes out of the ear. Once again, this is an assay that we can do both in animals as well as in humans, and the otoacoustic emissions are going to serve as a proxy for measuring outer hair cell function. And once again, if outer hair cell function is relatively intact, then we can presume in that region of the cochlea that the remaining portion of the cochlear structure is probably intact. Finally, this we definitely, unfortunately, cannot do in animals, but doing word recognition scores is one of the most common ways that we measure hearing. And I just wanted to make the point that the average adult cochlear implant patient for constant nucleus, constant word scores in quiet will get something like 50% or 60%, not quite 100% hearing, which would be normal hearing, although far better than the 0% of complete hearing loss. Also familiar to all of you, we know that earlier intervention is important, and that if you delay intervention for cochlear implantation, that you have decreased performance with regards to your ultimate performance with regards to speech. And if you implant somebody beyond the age of, say, 6 or so, the speech that they will develop is not particularly good. We don't know if we were to restore hearing through some sort of biological therapy, as I'm about to describe to you, exactly whether or not there would be a similar critical period as we have with cochlear implantation, or whether or not there would be a greater time or elasticity. Since we have never truly had the ability to restore seemingly native hearing to the ear, it will be very, very interesting in the future to see whether or not the critical period and performance will have, say, a wider intervention window, an earlier intervention window, etc. So roughly 1 in 500 or 1 in 1,000 newborns is born with disabling hearing loss. And amongst those newborns that are born with disabling hearing loss, something like 20 to 40%, depending on the population you look in, has some sort of complex etiology. In the United States and worldwide, amongst the most common causes is CMV. But there are also a variety of other causes, including infections with other agents in utero, as well as developmental abnormalities or potentially toxic exposures. However, genetic causes probably represent between 60 to 80% of the hearing loss that occurs in newborns and young children. And this is split between non-syndromic and syndromic causes. Amongst the non-syndromic causes, you can have recessive hearing loss. And in recessive hearing loss, this is the kind where the parents probably don't have hearing loss, but the children will. So you need 2 copies of a mutated gene in order to express this. Dominant hearing loss, where it's common that the parent might have a copy of the dominant gene and pass this on to the child. You only need 1 copy of the dominant gene to express dominant hearing loss. As well as mitochondrial hearing loss, which is passed on obligately through the mother to the child. which is rarer, but still not that uncommon. Syndromic hearing losses represent 20 to 25%. This includes things like Jervell-Lang-Nielsen, which has long QT along with hearing loss, Pendred syndrome, which has thyroid abnormalities and enlarged vestibular aqueduct, as well as Usher syndrome, vision loss and hearing loss, etc. One thing that I would like to emphasize is that it's extremely important to do genetic testing of children and also potentially even adults now who have sensorineural hearing loss in order to understand the etiology of that hearing loss. Based upon the genetic testing, we can get a variety of pieces of information that are important. One piece of information that we can get that's important is we can predict the progression of hearing loss. Some hearing losses will very rapidly progress. So, for example, if you have a mutation in SLC26A4, which is the cause of Pendred syndrome, about half of children are born with close to normal hearing, but their hearing will decline very rapidly over the course of the first 5 to 10 years of life. So as a consequence, if you have a child that tests positive for this, even if they don't have hearing loss, we should do reasonably frequent audiometric testing of that patient. Also important is identifying anything syndromic. So if you were to identify that somebody has Alport syndrome, for example, you should monitor closely their kidney function and refer them to a nephrologist. Similarly, if they have Jervell-Lang-Nielsen, that predicts long QT syndrome, which can cause sudden death, and you can intervene by things like beta blockers or AICDs and potentially prevent larger problems. Usher syndrome, also, for example, you would want to refer very rapidly to an ophthalmologist in order to ensure that patients get appropriate care there. So being able to diagnose syndromic hearing loss is another reason why it's important to test for the genetics. An additional reason is that it can help you resolve diagnostic dilemmas. So one example that I'm going to talk about quite a bit more is a gene called otoferlin. And otoferlin causes an auditory neuropathy type of syndrome. I think auditory neuropathy is one of the more challenging conditions that we as otolaryngologists and audiologists tend to treat in children. And I think you can all probably relate to the diagnostic challenge that you have when you have a child that maybe can detect something on behaviorals, on pure tones. An ABR might be relatively absent. Maybe a MRI is indeterminate with regards to seeing whether a nerve is there. And we have a tendency to say, well, let's wait 6 months and retest this child to see if they develop speech. And they might not be developing speech. And it could be sometimes age 3 or 4 before you finally realize, yes, this child is really going off the path and might benefit from a cochlear implant. And we have a tendency to delay cochlear implant in a lot of these children as a consequence of diagnostic dilemma. However, if you were to do genetic testing and find that a child has a mutation in otoferlin, I can tell you with some degree of certainty that that child will probably not develop speech in the absence of being able to have a cochlear implant. So it can resolve the diagnostic dilemma and tell you this cause of auditory neuropathy will probably respond very, very well to a cochlear implant, at least on one side. Whereas if they didn't have mutations in that particular gene, it might predict worse prognosis with a cochlear implant because there may be cochlear nerve deficiency or more central deficits there. So one thing that I do want to encourage once again is genetic testing is very, very important. And I will tell you in a little while, we are working very, very hard to decrease the barriers for people being able to get genetic testing. And we have a sponsored genetic testing program, which we are hoping to expand into Mexico in the new year, that would provide genetic testing at no cost to children who have bilateral sensorineural hearing loss. So when we think about genetic hearing loss, there are many different genes that have been associated with hearing loss. And there are now over 200 genes that have been identified that are responsible for causing hearing loss, either in humans or in mice. So in the future, our ability to diagnose and determine eligibility for clinical trials is going to be predicated upon our knowledge of what the specific genetic diagnosis is in an individual child and which of these genes they have a mutation in. One thing to mention is that the most common mutation or the most common gene mutated in most populations is GJB2, which encodes for connexin 26. That particular gene is not expressed within the hair cells. It's primarily within the supporting cells and fibrocytes within the inner ear. However, there are a number of mutations that are expressed primarily in the hair cells. Otoferlin, like I told you about here. Myosin 7A causes Usher's 1B. Clarin 1 is Usher syndrome 3A. And those are expressed in both inner and outer hair cells. Stereosilin mutations are relatively common, at least in the United States. Those mutations cause dysfunction of the outer hair cells. And as another example here, if patients have mutations in stereosilin, those patients tend to have roughly a 50 to 60 decibel hearing loss, consistent with loss of outer hair cell function, but we would not predict that their hearing loss would progress beyond that. And so that's important prognostic information for a patient to hear. If you have 50 to 60 decibel hearing loss, hearing aids will probably benefit them a great deal, and they are unlikely to progress to being a cochlear implant candidate. So you can guide the discussion and the counseling of patients based upon knowledge of that particular mutation. A similar argument would be made for KCNQ4, which is amongst the most common dominant causes of hearing loss here. There's another reason for people like me who are designing drugs for hearing loss here, that it's important to understand which mutations are present, because the different genes are present in different cells within the inner ear. And when we are designing gene therapies, our gene therapies are targeted to different individual cell types within the ear. And so as a consequence, we have to have knowledge of which cells we are going to be trying to deliver genetic material to in order to appropriately make drugs. And actually, I'll just stop briefly and say, am I speaking too fast for my interpreter colleagues, or are we doing okay? No problem. I will try to slow down a little bit and speak a little bit more clearly. Okay. So one question is, with genetic testing, what fraction of the time can we expect to get a genetic diagnosis? This is an example of a paper that was done in China where genetic testing was done with a panel of over 200 different genes. So you can test for all 200 different genes that cause hearing loss simultaneously. And in this particular series in China, they had a diagnostic yield of roughly 50% or so, meaning about half the time you can say definitively what the individual mutation is that is causing the patient's hearing loss. You can see that the most common things were GJB2 and SLC26A4, which causes Pendred syndrome associated with enlarged vestibular aqueducts. And then amongst the remaining genes, there is a wide variety of different mutations that tend to cause hearing loss. So how is it that we can start to think about addressing these using biological therapies here? And I would like to talk to you a little bit about doing gene therapy in particular. So what is gene therapy? The basic idea of gene therapy is that you use some method to deliver genetic material to appropriate cells in order to reprogram those cells to improve the hearing of patients by some fashion. And there are a variety of different approaches that have been taken in the past to be able to do this. And I will describe in more detail how the gene therapies that we are developing are working. However, generically, one of the simplest ways of thinking about gene therapy that we use is to transfer a working copy of a gene into a cell that lacks a working copy of a gene. So the idea here would be that a certain cell is not working properly because it doesn't have a functioning copy of the gene. You deliver DNA encoding a working copy of the gene, and now the function of that cell is restored. And let's say that this is a hair cell. Another approach that can be taken is therapeutic protein expression, where you deliver the DNA for a certain protein that has some sort of therapeutic benefit. And then you use the cell essentially as a factory for that protein, and you can make that protein durably for years and years and years and have a therapeutic benefit either on the cell itself or on some neighboring cells. An additional technique would be something like gene knockdown. So if you have a dominant condition, for example, where a mutated copy of a gene is producing a toxic species of protein that is inhibiting the function of a cell, you could deliver genetic material that eliminates the function of that toxic protein and hence restore function to the cell. This might be an approach that you would use for dominant conditions as opposed to recessive conditions. And then finally, there's gene editing, where we can actually correct the individual mutated copies of cells within the genome itself. So instead of providing an additional piece of DNA that encodes a working copy of a gene, as in gene transfer, what you would do is deliver either protein or DNA that alters the genetic sequence of the genome itself in order to restore function to cells. So in order to apply gene therapy to the inner ear, what we have devised is a system where we take in our first iterations, a working copy of a gene, we package it into a viral vector. So we take this DNA and we have to deliver it to the cells somehow, because if you just place DNA next to a cell, it usually will not take up that DNA. So there needs to be some method by which that DNA is delivered to the cells. One commonly used method these days is by packaging it into this viral vector called adeno-associated virus. Now, adeno-associated virus is a generally non-pathogenic virus that isn't capable of replicating and which doesn't tend to cause disease in humans. So we remove its normal genetic material and package the genetic material encoding the gene that we would like to deliver within that viral shell. And then we inject this virus directly into the inner ear, where it can then transduce the cells of the inner ear, deliver the genetic material, and restore function to those cells. So I'm just going to check the chat quickly to make sure. Okay, terrific. All right. So next, how are we going to deliver this to the inner ear? So over the course of the past 6 years or so, we have worked very hard to come up with a safe surgical technique for delivering things to the inner ear. And we have devised a delivery device, which looks a little bit like a curved needle that you might use in the operating room, that has a little stopper here and has a hollow bore. And what we do is do a transcanal approach. This can be done either under the microscope or using an endoscope, where you gently lift a tympanomeatal flap. You have to create a vent hole into the inner ear. So using a laser, you create a little hole in the stapes foot plate here to allow for egress of fluid. Then you introduce your delivery device, which has the fluid that contains the virus, and you inject the fluid into the inner ear. Because fluid is incompressible, if you were to deliver the fluid to the inner ear without creating the vent hole, it would just back up against you and not enter the inner ear. However, if you create this vent hole here, then what you can see in this model of an unrolled cochlea, the fluid is injected into the scala tympani, travels along the length of the cochlea up to the cochlear apex, crosses the helicotrema, and then exits through the stapes foot plate in that fenestration. And this then bathes all of the cells of the inner ear with the virus that we are going to be delivering, so that it can then fuse with the cells and deliver the genetic material. Once the injection is complete, you can seal off the round window and the oval window membranes using either a blood patch or helon or tissue or hyaluronic acid, a variety of different techniques, very similar to what we might do in a stapedectomy procedure. So we have devised a technique where we can study this delivery procedure in mice, in non-human primates like cynomolgus macaques, as well as in humans. And the approach in humans and non-human primates is very, very similar. One thing that I will mention is that because mice are so small and the cochlea is so small, it's very, very difficult to do this technique in mice, but fortunately I have an outstanding team that is capable of doing this. In non-human primates as well, the surgery is actually a little bit harder than it is in humans because it's smaller, and instead of fenestrating with a laser in the stapes footplate, you need to blindly place a curved needle in there, which creates a little bit more damage at the base of the cochlea. And so in non-human primates, we see a little bit of damage sometimes to the base of the cochlea that we do not expect to see in humans. Okay. So next, we had to select a particular viral capsid that delivers the material into the inner ear. And there are different versions of this adeno-associated virus. And the capsid that we chose is one which is called AAV-ANK80, which is presumably an ancestral sequence to existing adeno-associated viruses that circulate out in nature. The one property that is important about this AAV-ANK80 is that it is very, very effective at delivering genetic material to hair cells, to inner hair cells in particular. And so if you look in this experiment, which was done in mice, where mice were delivered either AAV1, AAV2, AAV8, or AAV-ANK80, that expresses a green fluorescent protein, which when the DNA is delivered to those cells, makes them turn green and fluoresce. What you can see here are whole mounts of the organ of Corti, and we are seeing inner hair cells here. Here's one row of inner hair cells, and then here are the 3 rows of outer hair cells here. And you can see at a much lower dose, so 10-fold lower dose of ANK80 compared to some of these other capsids, we can transduce nearly 100% of the inner hair cells here. And you can see that the other capsids that were tried were much, much less efficient at delivering the genetic material to the inner hair cells. In this review paper from some colleagues of us from Europe, people have now started doing these experiments in mice and in other animal species with a variety of different capsids. And what you can see is that if you compare the dose that's delivered and the efficiency of delivering genetic material to the inner hair cells, AAV-ANK80 is much more potent and much more effective at delivering the genetic material to inner hair cells at much lower doses than some of the other capsids. So as a consequence, we selected this capsid to deliver the genetic material. So we have a pipeline of different gene therapies that we are working on currently. Because we can package whatever we would like to this virus, there are different pieces of genetic material that we have. Our program that is currently furthest along is for otoferlin-mediated hearing loss, and I'm going to be talking more about this particular program. We also have a program for Usher syndrome type 3A, caused by Clarin. We have other targets that are autosomal dominant. We have a program for GJB2 hearing loss that is in its preclinical stages. And we also have been using this for hair cell regeneration, where we can deliver factors that reprogram supporting cells into hair cells with the hope of being able to apply this technology very, very broadly for age-related hearing loss and presbycusis. This is earlier stage, but we've made some very exciting progress on this front, and this is some of the things that I'm most excited about. Finally, the next program that we have that is about to enter clinical trials is for anti-VEGF antibody for patients with vestibular schwannomas. This is based upon the finding in patients that have neurofibromatosis type 2, administration of anti-antibody is capable of slowing or stopping growth of their vestibular schwannomas, and in some cases actually restoring hearing to patients. So the idea here is to package an anti-VEGF antibody encoded in DNA and deliver it to the inner ear, then use the cochlea as a factory for anti-VEGF to be delivered only locally to the vestibular schwannomas without the systemic side effects that we would see with systemic delivery of this drug. So I'd like to focus a little bit more on our first program that is in clinical trials, which is for auditory neuropathy caused by mutations in this protein called otoferlin. Now, otoferlin is a protein that exists only in inner hair cells, and it is a protein that sits on the vesicles at the basolateral membrane of hair cells, and it functions as a calcium sensor. So when hair cells depolarize, otoferlin detects the calcium that flows into the cell and causes fusion of the vesicles where glutamate is dumped at the synapse, and then there's onward transmission of the signal along the spiral ganglion neurons and back to the brainstem. In children that lack otoferlin, they cannot fuse their vesicles. Therefore, the hair cells depolarize, but there's no onward transmission of the signal back to the brain. Therefore, the children tend to have severe to profound sensorineural hearing loss. Because it is specific to the inner ear, however, the outer hair cell function tends to be intact. As a consequence, you get an auditory neuropathy phenotype, where you have intact otoacoustic emissions, but absent ABR in these children. And so this gives rise to that characteristic auditory neuropathy phenotype. We performed a large literature review of all of the children and adults that had been published that harbor mutations in otoferlin, and you need to inherit 2 copies of this. It is a recessive condition. 98.4% with absent ABRs, either severe or profound sensorineural hearing loss, but their otoacoustic emissions tend to stay intact, and they can stay intact for quite a long time, up to age 11 and beyond. However, beyond age 11, they do start to drop off, which is consistent with the notion that you start losing your hair cells and the cochlea is starting to decay. We think this is important because it's probably important if we are going to be delivering a gene and replacing it, the structures of the cochlea need to be intact. Therefore, in our clinical trial, we are targeting children that have absent ABRs but present otoacoustic emissions. One thing to mention, based upon preclinical data generated by Ellen Reisinger, if you fit children that have otoferlin with very high-powered hearing aids, they tend to not get that much benefit from their high-powered hearing aids, but they are more sensitive to losing their otoacoustic emissions, probably as a consequence of loss of efferent feedback. That might be important because loss of otoacoustic emissions would render children ineligible for our clinical trials and might make it so that they cannot benefit from gene therapy later on down the line. We don't know that definitively, but that is something that is predicted based upon animal studies. So for otoferlin is a very large gene, and there's limits to how much DNA you can package within an individual virus. Therefore, for this particular gene, we had to package the gene in 2 separate viruses and split it between a 5' half and 3' half. So we mix these viruses together, and when we inject them into the inner ear, both viruses will then fuse to and deliver their genetic material to inner hair cells, where those 2 pieces of DNA can then recombine and create full-length otoferlin when delivered to inner hair cells. One thing that is important here is that we have a mouse model of otoferlin-mediated hearing loss that looks very, very similar to the humans that have otoferlin-mediated hearing loss. And so these mice, like humans, have an absent ABR, but present otoacoustic emissions early. However, if you look at the otoacoustic emissions as these mice age, they tend to lose them as the mice age. So here you can see 3-week-old mice have intact otoacoustic emissions, but then these 10-month-old mice have almost absent otoacoustic emissions. So when we deliver otoferlin to the inner ear of these mice, what you can see here, this is a picture of the organ of Corti. Here are inner hair cells, here are outer hair cells. And in this fluorescence image, we are detecting the otoferlin protein in a wild-type mouse. This is a normal mouse that has otoferlin. And you can see the yellow indicating the expression of otoferlin within the hair cells. Here is an image that we took from a mouse that lacks otoferlin, but was delivered vehicle, that is, virus not containing otoferlin, and you can see that there is no otoferlin expressed in the inner cells, indicated by the green cells here. However, once we deliver our viruses to the mice and inject it into the cochlea, we restore expression of otoferlin within the inner hair cells. what you can see here, these are micrographs from non-human mates that we have with otofurlin. Once again, you can see the expression of otofurlin within the inner hair cells of the non-human primate, which is a more relevant translational model. Now, here is probably the most exciting part of this talk. So when we take our mice that lack otofurlin and we inject the virus that encodes otofurlin into these mice, either at low dose or high dose, we restore hearing to the mice. So what you're looking at here on the left is what fraction of mice have present auditory brainstem response. So over here in the teal, you can see that mice that are otofurlin knockout mice that are just administered vehicle, that is fluid that doesn't contain the virus that encodes otofurlin, have no recovery of hearing here. Whereas wild type mice have essentially normal ABRs if you follow them out from 1 month, 3 months, or 6 months. Animals that we have administered the gene therapy to their ear at either low dose or high dose have very robust restoration of their auditory brainstem response at the higher dose, which is close to our top clinical dose that we will be administering in our clinical trial. We see nearly 100% of the animals now have detectable ABRs. If you look at the degree of restoration of ABRs, you can see here are wild type mice, so this is normal hearing for a mouse. Over here, this is our knockout mice. They have no detectable ABRs whatsoever. And at low dose, we see some restoration, but at high doses, we see much more robust restoration of ABRs. And if you look at 6-month-old animals, the majority of animals within the higher dose group have restoration within the wild type range of hearing for the ABRs. We do see some amount of scatter of ABRs even in the normal mice that we've injected with vehicle, because they're so small and the administration procedure causes a little bit of damage, which we would not anticipate in the human procedure. One thing that we noted was that some animals responded and some animals didn't respond, and it looked like as long as we delivered the protein or delivered the DNA to at least 20% of the inner hair cells, they had very robust restoration of their hearing. This dovetails nicely with some of those previous otopathology studies that were done that demonstrated that that you could lose 70% of your hair cells before you start seeing a substantial decline in your pure tone averages. So I will just mention briefly here, because time is running short, I will mention briefly here that that we did experiments where we injected animals that were either neonates or juveniles with fully formed cochleas and saw restoration of hearing. But if we inject animals that are much later, after their otoacoustic emissions have declined already, we do not see evidence of restoration if the otoacoustic emissions are absent, consistent with the notion that you need to have intact structures to be able to deliver the genetic material to in order to see good restoration. Finally, we delivered doses of our drug at 3 different doses, including doses higher than we are anticipating needing to administer in humans, to a large number of non-human primate monkeys, and saw no substantial evidence of toxicity, of loss of hair cells, or any systemic side effects as a consequence of delivering the genetic material to the inner ear. So we are very excited about the possibility here that we would see a similar restoration with little toxicity in humans. So as a consequence of these findings, we have initiated a phase 1/2 clinical trial, and this clinical trial is open and actively recruiting right now. So there are sites that are open in the United States currently, and we are about to open some other sites internationally as well, so stay tuned with that. One thing to mention, because we don't want economics to be a barrier for people to be able to participate, and we want to make this clinical trial accessible to people all over the world, if there are patients that are local that meet the eligibility criteria, we have the ability to sponsor their travel and housing to be able to travel to clinical trial sites so that patients can access this no matter where they are. So our phase 1/2 clinical trial is including children as young as 2 years of age. So it's for kids 2 years of age and older, although in later phases we may go even earlier than that. And the important eligibility criteria is that patients need to have had genetic testing demonstrating mutations in the otoferlin gene. They need to have absent auditory brainstem response and present otoacoustic emissions. And the kids cannot have bilateral cochlear implants. So if they have one cochlear implant, that's fine. If they have two cochlear implants in this phase, we cannot, they are not eligible for the trial. We are also concurrently conducting a natural history study in individuals that have otoferlin-mediated hearing loss, that we can understand this condition better and its progression. If you'd like more information, you can go to the website that's listed here and search for ACUOS. I can also send along a link to some information about the trial. I put this up here as hope for the future. So this is a list of genes where people have done gene therapy in mice and shown evidence of either preservation or restoration of hearing. And we have a long list of things to work on as the future of gene therapy and the next things that we will be working on. So I'm very, very excited about this as the future. Finally, we do have a sponsored testing program right now, which is just open to people in the United States. But stay tuned. In the new year, we are anticipating expanding this out to other countries, potentially including Mexico. So if and or when this gets up and running, I will be very excited to come back to you and make this accessible for the patients that all of you guys work so hard caring for. And so finally, with that, I would like to thank you so much for the kind invitation to speak, and I will take any questions.
Muchas gracias, doctor
My
Ward, por
pleasure.
esta maravillosa exposición. El tema de genética, creo que para todos los que somos médicos, desde que estábamos en la universidad, y pues probablemente hace 20 o 30 años la materia era un poco más como ciencia ficción. Hoy es un gusto poder escuchar esto como una realidad, y sobre todo en un tema tan interesante que es en una función neural. En aquella época estamos acostumbrados a escuchar que las neuronas o sus terminales no se pueden reproducir, no se pueden mejorar, y una vez que la perdemos, pues es para siempre. Y esto realmente es una luz muy importante en el camino que se pueda llevar a cabo, y por lo que nos ha mostrado, pues es una luz ya muy firme, muy bien establecida, y es muy interesante para los que manejamos pacientes con hipoacusia poder tener esta situación. Sabemos que la hipoacusia es una discapacidad muy frecuente, y probablemente sea una discapacidad con mayor repercusión emocional para los pacientes, inclusive tal vez mayor que la discapacidad visual. Entonces, pues esto es un aliciente muy importante para la población y para el ser humano, que es un ser que se tiene que comunicar por naturaleza. Vamos adelante, doctora Rodríguez, por favor.
Muchas gracias. Bueno, pues antes que nada agradecer al doctor Aaron, una gran plática, y la verdad es muy emocionante pensar en lo que ya está pasando ahorita y lo que viene en los siguientes años. Tengo el gusto de presentar el día de hoy a dos doctoras que realmente son excelentes en su área, y tengo también el privilegio de trabajar con ellas desde hace algunos años. Les presento primero a la doctora Alma Medrano Hernández. Ella es egresada de la Universidad de Anáhuac. Después hizo genética clínica por la UNAM. Tiene una maestría en administración de instituciones de salud por la Anáhuac. Es candidata a doctora en ciencias biomédicas por la UNAM. Tiene la alta especialidad en medicina de precisión oncológica de la UNAM y neurogenética por la UNAM. Tiene una larga experiencia en docencia, y desde su punto de vista clínico tiene más de 15 años de experiencia en la práctica clínica de genética, neurogenética y oncogenética. Es también autora de muchos libros y artículos sobre precisión en neurología, genética clínica y oncología médica. Y nos estará acompañando para algunas preguntas. Por otro lado, también tengo el gusto de presentarles a la doctora Laura Rocío Alonso Luján, ella es egresada de la Universidad Panamericana, después hizo la especialidad médica en comunicación y audiología y foniatría, y después el estudio de posgrado de audiología pediátrica en el Instituto Nacional de Rehabilitación. Ella tiene una amplia experiencia en implantes cocleares, ha formado por mucho tiempo parte en los comités de implantes cocleares, primero en el INR y ahora de forma privada y también en un programa de Escuchar Sin Fronteras. Ha dirigido varias tesis, varios artículos, autora de muchos libros. Y bueno, sin más con el gusto de presentarles a estas doctoras, quisiéramos empezar con algunas preguntas para el doctor Aaron. Denme un segundo. Bueno, aquí en el chat, perdón. Empezamos por algunas preguntas del chat. Las primeras agradeciendo su plática y muchas felicitaciones. Le preguntan, bueno, la primera pregunta sería, el seguimiento en los ratones ha sido por 6 meses. Más o menos esto, ¿a cuánto equivaldría en el seguimiento en adultos?
Yes, it's a good question. So we have followed mice now out almost a year and have not seen any decline in function at this point. The nature of these therapies is that the DNA is delivered to cells and maintained very long term. So there's the potential here that the delivery is one time and will last for life. Other gene therapies delivered by AAV in humans have been shown when they are in non-dividing tissue like the ear to be durable out to about 10 years and beyond. It's early days yet for gene therapy, but the hope is that it would be maintained very, very long term and not require another dose. However, it is possible that the function might decline over time and that you would have to redose at some point, but these are designed to be long-term, durable for many, many years.
Muchas gracias. Los casos que tienen como non-responders, los que no respondieron, ¿tienen alguna hipótesis del por qué no respondieron? ¿Habrá sido por la técnica o alguna otra cosa?
Yeah, correct. So in the cases, the data I was showing you is from mice. Those that don't respond, we are pretty sure it is a consequence of being at relatively low dose and therefore not enough cells received the virus. So it was probably just at the low end of a therapeutic dose, and that the dose needs to be higher to be able to transduce an appropriate number of cells. So we think that as long as the dose is at an appropriate dose, that will be less of a problem. However, one would predict that if you were to do an injection and not deliver the full dose, you might not have full benefit if all of the fluid didn't go into the cochlea, for example.
Perfecto. Tenemos otra pregunta de parte de la doctora Hinojosa, que si considera que estos pacientes van a requerir algún tipo de terapia de rehabilitación en cuanto a la función auditiva, después de la aplicación de la terapia génica.
Yes, yes, that is a very good question. It's early days yet, and we are just starting to be dosing patients in our clinical trial. So as a consequence, we don't yet know exactly where patients are going to land. In a perfect world, if they were to get, close to normal hearing, almost certainly they are going to require some amount of hearing rehabilitation. But probably more likely what will happen in some of our first patients, especially if they are a little bit older, is if it works well, they may well be restored to a level that they would still require hearing aids. But even that, I think, would be a large benefit to them. Additionally, for these patients, their brain has not been receiving input in the same way that children with normal hearing have been receiving input. So I suspect that additional hearing rehabilitation and listening exercises would probably be very beneficial for them as well.
Alma, te dejo la palabra.
Muchas gracias, interesantísima su plática. Muchísimas gracias. En México hemos estado teniendo justo un retraso en el abordaje molecular de los pacientes de muchas patologías y esto incluye las hipoacusias. En Estados Unidos, ¿qué tan frecuente es realizar un panel de hipoacusia en pacientes con una hipoacusia neurosensorial? ¿Qué tan frecuente es?
Yeah. I wish I could sit in front of you and tell you that it is much more common than it is. So in the United States, still it is very, very uncommon for people to get this. There are a few centers that do it very regularly, but most people don't incorporate it into their practice, largely because of barriers surrounding insurance reimbursement, as well as lack of familiarity with the panels, etc. It's part of this reason that I think it's so important for leaders such as yourself and all of us to try to emphasize the importance of genetic testing. And so as a consequence, one of the things that we are doing on our side is trying to do more education and sponsored genetic testing to decrease the barriers from a financial perspective to it. But the financial barriers are not the only barriers to it. There are additional barriers with regards to clinical protocols and the education of physicians and audiologists who might not be very familiar with these different genetics as well as the ramifications of these things. So we are also working on trying to provide support so that reports go to audiologists and physicians that have usable information that they can interpret to combine with their care and hearing rehabilitation. In other countries that have more nationalized systems, it tends to be better protocoled. So I know in countries like Korea and in Denmark, for example, they have much broader adoption of genetic testing, but the United States is very balkanized.
Muchas gracias. Tengo unas preguntas relacionadas justo con la terapia. La primera ya la respondió si considera que requerirán más de una dosis. Entonces entiendo que lo esperado es que solo se requiere una dosis, ¿cierto?
That is correct. That is the hope. It's what these things are designed to do, and we are hopeful. Obviously, we will learn more throughout the clinical trials what the durability is, and we'll really get those answers as years go on.
Ok, perfecto. ¿Se generó algún tipo, o sea, es un virus, vaya, ¿se generó algún tipo de respuesta inmunológica? Sé que es un lugar inmunológicamente especial, sin embargo, pues bueno, o sea, hubo un procedimiento quirúrgico, etcétera. ¿Se generó alguna respuesta inmunológica?
Yes, that's a very good question. So we saw very mild, if any, immune response locally in the ear. So we do not see evidence of substantial immune infiltrates, with the exception of directly at the injection site. But throughout the rest of the cochlea, we see very little immune response. Pre-existing antibodies against these viruses don't seem to inhibit the ability of the virus to be able to transduce the cells. Although we can see that when we inject this into the ear, in the blood, we can see an induction of antibodies against the virus, but that does not seem to cause problems with regards to the expression of the protein later long term. We have done some experiments to see if the immune response inhibits the ability to deliver or express the proteins in the ear. So we did one experiment where we immunized non-human primates and then delivered to the ear and saw no difficulty with transduction. We did another experiment where we dosed one side, waited a month, and then dosed the other side and did not see difficulties with transduction there either. So this was encouraging to us with regards to a lack of immune response. Obviously, hopefully this will translate to humans as well, but we will find out in the clinical trials.
Ok. Y mi última pregunta es, la respuesta no va asociada al tipo de mutación en OTOF, ¿cierto?
Yeah, that's a good question. So we have delivered in non-human primates, as well as in mice, viruses encoding a wide variety of these different genes, as well as green fluorescent protein and other proteins. And we have not seen major differences with regards to immune response to different things that we are delivering within the virus at this point. We suspect it's because the cochlea is a more immune privileged site, similar to the eye, perhaps, or even perhaps even more immune privileged than that.
Ok. Por mí sería todo. Muchísimas gracias, interesantísima y gracias por la información.
My pleasure.
Doctor Alonso.
Doctor, pues muchísimas gracias por su participación. La verdad es que es maravilloso escuchar que el futuro nos alcanzó y que ya estamos en esa etapa. Y bueno, dentro de mis preguntas está, sabiendo la importancia de la detección oportuna y la intervención oportuna, ¿cómo piensan abordar el hecho de hasta dónde esperar o no implantar a un paciente de forma bilateral para que ingrese a su protocolo? Y esa sería como la primera pregunta.
Yes, that is an excellent question. So I should say that it is absolutely critical that patients be provided access to sound as soon as you feasibly can give them access to sound. That is absolutely critical. In my mind, I would say that it would be reasonable to implant one side, and if a patient were eligible for a clinical trial, to then counsel them about the other side and let the patients decide if they might want to participate in the trial. But I still would not delay the first-sided implant. I think that is critical. There are some patients, there might be a small number of patients who are very excited about the trial, who would want to say, well, let me try the gene therapy first, and if that doesn't work, we can always go in and implant later. I am not in favor of that because I would not want to delay and forego access to sound, at least on one side, as soon as is humanly possible. This also brings up the issue of, well, what about for other therapies, like for GJB2 or something like that? And my attitude is I would do bilateral implants unless there is an open clinical trial that a person would be eligible for. I would not save an ear for some potential future benefit if there is not the immediate possibility that a patient could enroll in a trial. Because I think all of us have been hearing for many, many years, oh, these great therapies may just be around the corner. And the reality is that it takes a very long time to develop these things, and it's going to be coming in for different conditions at different times. So my advice is, if there's no open clinical trial, bilateral implantation immediately. If there is an open clinical trial for this particular patient's condition, unilateral implant, and have a discussion about the second year.
Gracias. Y la otra pregunta es si en su protocolo tienen establecido para estos pacientes en que se aplique la terapia en un oído y el implante en el otro, ¿hasta qué punto esperar el resultado? ¿Cuánto tiempo de espera para el resultado que ustedes están esperando para poder pensar entonces en implantar o que el paciente utilice un auxiliar auditivo de ese otro lado?
Yeah. That's a good question. So in the mice have hearing restoration as fast as the gene expresses, and typically they are close to essentially their level of hearing within a month or so. We anticipate the human clinical trial that it will probably take a month or two to see the results there. But I think if we do not see an effect within about 6 months or so, I would probably recommend that child then progress to implantation on that side. And I think that that gives us enough time to establish whether or not there have been any significant changes, but also balances it with, I think, the needs of early implantation for children, especially if they have the implant on the other side.
Gracias. Y por último, más que una pregunta, es como un comentario, y que ya comentaba la doctora Medrano en México, pues la limitante y también el rechazo de muchas veces los padres para que se hagan este tipo de test, o están enfocados también a la parte rehabilitatoria y dejan para después esta parte de la valoración genética. Creo que un poco el darles esta esperanza de tratamiento y que hasta ahorita las opciones que nos dicen, y voy a escuchar igual que sí, o va a escuchar, ¿no? Mi hijo, igual que yo escucho, y la respuesta hasta ahorita, pues sabemos que es no, ¿no? Nada va a igualar a la audición natural, y a lo mejor el proporcionarles esta herramienta de tratamiento y que va a ser ahora sí el sí, van por los estudios, ¿no?
Yes, I agree with you completely. And, you know, although those of us who are passionate about the genetics, who do the genetic testing all the time, obviously we know there are other benefits in addition to this. But one of the things that I commonly hear from some of my colleagues who say, well, why should I do the testing? What are we going to do with the information? We're just going to do a hearing aid or an implant anyway. And I think the possibility that, you know, you might be eligible for this and that there is real hope, I think may well change the minds of both our colleagues as well as some of our patients with regards to accepting the genetic testing. One last comment that I'll make also that I think is an important feature here that I would be very excited about with this particular therapy is it offers the possibility of being able to have some hearing without necessarily needing to program and maintain an implant. I think for a lot of patients, especially if they are in under-resourced areas or don't have great access to audiologists, really it's very, very difficult to maintain a cochlear implant and utilize it over time. And so the prospect of a therapy that can be done once and give a durable benefit, I am particularly excited about with regards to the distribution of hearing benefits to those who are in resource poor settings.
Muchas gracias, doctor.
Muy bien, pues estamos viendo cosas muy interesantes que nos levantan la curiosidad a todos, tanto clínicos como quirúrgicos. Yo quisiera preguntar, doctor Ward, que pudiéramos para irnos adentrando a los que tenemos poca experiencia en genética, ¿cuál sería el tipo de paciente con hipoacusia sensorineural que debe ser sometido a un estudio genético? Desde luego, bueno, si el paciente es sindromático, pues bueno, tiene que serlo. Pero en un paciente no sindromático, debemos hacerlo, en un niño, hablando del niño, debemos hacerlo en todos, o hay algunas características, como puede ser la historia familiar de hipoacusia, que son las que nos deben orientar qué él debe ser, o para ustedes hoy en día, todo niño con hipoacusia sensorineural que no sea explicada por algún daño durante el embarazo o en el nacimiento debe recibir un tamizaje genético.
Yes, this is a very good question. And the question is a little bit complicated because obviously one of the concerns also involves resource constraints as well. And when there are more resource constraints, you need to prioritize those patients for testing that are the most likely to derive benefit from the testing. But I would say that in a perfect world with unlimited resources, any child that has bilateral sensorineural hearing loss should be tested. And in fact, there are some places that are beginning to do universal genetic screening in the same way that you would do universal newborn hearing testing. So for example, in the province of Ontario in Toronto, they do a genetic test for GGA SLC2 and SLC24 on every child that's born in the province, which is amazing, as a way of earlier catching hearing loss. And I mentioned before why it's so important for SLC26A4, because half of those patients will pass their newborn hearing screen. But I would say a good rule of thumb is any child that's born that has bilateral symmetric sensorineural hearing loss should receive genetic testing. Those that fail their genetic screen and on a diagnostic audiogram have confirmation of bilateral sensorineural hearing loss, I would do genetic testing. One step up from that, certainly any child that is a cochlear implant candidate, I would get genetic testing on. Children that have enlarged vestibular aqueduct on a CT scan should get genetic testing. They will most frequently have SLC26A4 mutation, but they might also have POW3F4 mutation. And I think you can even consider in adults as well, adult cochlear implant patients, you can get genetic testing. That has some prognostic importance for the outcome with the cochlear implant, as well as their family. Certainly, if there's a family history of hearing loss, they should get genetic testing, especially if it's
Esta parte que menciona en relación al desenlace del implante coclear, para nosotros los cirujanos, pues es muy interesante, ¿no? A veces pensamos que el hecho de haber colocado el implante fue la solución total y definitiva, pero pues en algunos casos no será de esa manera. En esto que nos comenta del tamizaje genético, en la actualidad, de lo que se está aplicando, sabemos que hay más de 200 genes que pueden estar asociados a la hipoacusia, pero en el tamizaje actual que se puede estar practicando, ¿qué cantidad de genes son los que se pueden utilizar como tamizaje, como prueba inicial de detección?
So at this point, most places are switching over to testing a panel of, say, these 200 genes, so all of them simultaneously, essentially. It's actually more expensive to test the individual genes one by one at this point than it is simply to do the entire panel. And so essentially, most places that are doing testing are either switching or have already switched to doing a full panel of testing. And there's some variety as to exactly which genes are included, but most of the panels contain somewhere around 200 or so.
Es decir, bueno, es una prueba prácticamente completa, ¿no? De los que se conocen en la actualidad. Tenemos algunas preguntas aquí en la plataforma. Algunas que estoy identificando, creo que nos hablan un poco más allá de lo que actualmente existe, es decir, nos están preguntando sobre cuál ha sido la respuesta de terapia génica en humanos en diferentes enfermedades. Y bueno, esto debe quedar claro que esto en los animales de experimentación fueron sometidos o provocadas sorderas, provocadas, no son relacionadas con ninguna enfermedad. Y en los humanos, por lo que nos presentó, tenemos algunos protocolos específicos, como pudiera ser para el PRENDED, como va a ser lo de schwannoma vestibular y algunas características en particular, ¿no? Quizá algunas de las preguntas de aquí todavía nadie las podemos contestar en cuanto al resultado en humanos en diversas enfermedades. Hay una que dice, ¿qué opinión tiene sobre la viabilidad de pruebas genéticas para tamizaje? Nos preguntan específicamente del gen MTRNR1 en neonatos, dado el riesgo que estos pueden tener por sordera, por fármacos por aminoglucósidos.
Yes. So I think this is a very important question. It's something I care deeply about. So currently, in a variety of places, there's newborn screening for a variety of conditions, not necessarily hearing loss, that is done by biochemistry, where we take a little bit of blood from a neonate and test for different metabolites for metabolic diseases, most of which are genetic, and screen that way for early intervention. I think as time goes on, we will have genetic tests for most of these other diseases. And what is probably going to happen is that the cost of sequencing and the cost of these tests will come down enough that every newborn will, depending on the ethics and regulations within an individual country, will have their whole genome sequenced, and then only those conditions which predict major problems where early intervention can help, we will be able to screen for these things very rapidly, and we could test for everything simultaneously, including the mitochondrial mutation. I think the mitochondrial mutation is a perfect example of something that should be tested for because of the importance of aminoglycoside toxicity and the commonality of that mutation and just how common aminoglycosides are used. I think all of us as otologists and audiologists wish that aminoglycosides wouldn't be used in neonates, but unfortunately, that is not the reality just yet. And so I do look forward to the time where there will be more universal genetic screening done that will include this as well as other hearing loss genes in those panels. It's a few years off, though. There are a number of places that are doing pilot programs, however, and I'm excited to see the results of those.
Perdón que interrumpa. Muchas gracias. Justo en el gremio de los genetistas en México hemos estado hablando muchísimo sobre la importancia del tamizaje y los pros y contras y lo relacionado con temas de acceso. Y es un tema controvertido por el hecho del costo de las pruebas. Sin embargo, algo que quisiera comentar de entrada, con un poco retomando la pregunta previa del doctor García Lara, es que la mayor parte de estas enfermedades son autosómico recesivas. Entonces, guiarse por los antecedentes familiares no es lo ideal, porque la mayoría no van a tener antecedentes, salvo las que son dominantes. De ahí la importancia del tamizaje que justo hemos estado hablando. Tamizar a todos es económicamente poco factible. Sin embargo, si tamizamos, y no pondría como tal el término tamizar, sino diagnosticamos a los que ya tienen la patología, en este caso, la hipoacusia de origen neurosensorial, es sumamente importante. El hecho, y lo hemos visto mucho en alteraciones del neurodesarrollo, el hecho de que hayan antecedentes en el embarazo que pudieran explicar, etcétera, es un bias, es un problema. O sea, no nos podemos guiar solo por eso, dado que perdemos pacientes que en realidad fue un evento que pues, sucedió y que no necesariamente es el que generó la hipoacusia. Entonces, y el otro punto es, en México tenemos la capacidad de hacer estudio molecular, tenemos el acceso a la misma tecnología que hay en Estados Unidos. Hay genetistas a los cuales se pueden acercar para hacer este tipo de abordajes multidisciplinarios. Hay genetistas en todos los estados. Entonces, no es que seamos raros, tienen, o sea, si habemos suficientes, debemos de formar parte del equipo multidisciplinario y pues nada, ya con eso acabó mi intervención. Gracias.
Yeah, I think those are terrific points. I agree completely.
Tenemos una pregunta en el chat de parte del doctor Corbera, que es un gran médico de aquí de nuestro país. La pregunta es que ¿en qué difiere la técnica reportada a inicios de este año por Frequency Therapeutics que no tuvo éxito?
Yeah. So, therapeutics, I did get the question. So Frequency Therapeutics was developing a therapy that was for hair cell regeneration using small molecules, chemicals, that they would inject behind the eardrum, so into the middle ear, not directly into the cochlea. And the hope was that this combination of two chemicals that were small molecules could induce supporting cells to transdifferentiate into hair cells. And so I think there are a variety of differences in the approach. Here we're using a virus to deliver a specific gene to hair cells. We're injecting directly into the inner ear rather than into the middle ear and hoping that it changes. And in addition, those small molecules, there was some controversy as to whether or not people could observe in animals that you actually see any regeneration of hair cells. I think most of the data was based upon looking at cells in a dish rather than looking at hair cells in a living animal's cochlea. And so this particular approach is quite a bit more targeted to specific pathology that we are looking at here. Hopefully, we can use this similar technology to inform us about doing things like regenerating hair cells and putting factors in that will convert one cell type into another. But I think it's a much more difficult task than simply replacing a single gene.
Muchas gracias. Tenemos otra pregunta del doctor Obed Benítez y nos pregunta sobre los resultados que si fueron de igual forma consistentes tanto para pacientes homocigotos como para heterocigotos compuestos o si había alguna diferencia dependiendo del tipo de mutación.
Yeah, that's a good question. So we are just in the clinical trials now, and we haven't yet reported out any results, and we're in very early stages. So we don't yet know the difference between how homozygotes versus compound heterozygotes would respond. Sorry, I'm just going to move.
Perfecto. Tenemos otra pregunta, si se realiza, ¿qué cantidad de material es lo que, bueno, de material se aplica en la cóclea? Y si después de aplicar el material se sella la ventana redonda, y si esto se hace de manera bilateral al mismo tiempo.
Translation.
Ok. Bueno, voy a repetir las preguntas. Son de parte de la doctora Edna Carrillo. ¿Cuál es la cantidad de material que se aplica en la cóclea? Si se oblitera la ventana redonda posterior a la aplicación. Y el doctor González pregunta si se hace de manera bilateral al mismo tiempo en los pacientes, ya en el clinical trial.
Yes, that is a good question. So do we obliterate the round window? So we don't obliterate the round window completely. Following the injection, the round window opens almost like a slit that you would make with a cochlear implant. And at the end of the procedure, you can place either a blood patch or tissue or Helon, something like hyaluronic acid, to help seal it off, but it is not completely obliterated. After the round window heals, presumably, if you're using a blood patch or hyaluronic acid, it would then be thin and not completely obliterated. The next question was about bilateral, doing this bilaterally. So in our current clinical trials, we're doing it unilaterally. In future phases, assuming there are very, very positive results, we can consider switching it to bilateral. But I think in the initial phases, we are planning on just doing it unilaterally while we establish what the efficacy would be of this. And then, was there a third question? I've now forgotten.
No, creo que nada más esas dos. Por último...
Yes, thank you very much. So the amount that we inject is is close to 100 microliters, so about half of the volume of the inner ear.
Por último, tenemos una pregunta sobre síndrome de Meniere, si existe alguna terapia génica para, bueno, sembrándose para este síndrome.
Yeah, very good. So patients that have SLC26A4 mutations tend to have some fluctuation of hearing, and they can also have a Meniere's-like phenotype. So, many people are working on therapies for that, although I don't think that they're quite ready for clinical trials just yet. There are a number of ideas that we and others have for how we might think about trying to address Meniere's with gene therapies by, say, altering either ion homeostasis or altering the fluid dynamics in the cochlea. But in the short term, I don't think that we are going to be seeing trials of gene therapy for Meniere syndrome within the next few years. It's going to be coming probably a little later than that.
Y en cuanto a los trials para schwannomas vestibulares, me imagino que la terapia va a ser local, igual aplicada en oído interno a través de la cóclea. ¿Y qué es lo que esperarían con estos trials? ¿Una reducción del volumen del tumor que deje de crecer? ¿Algo de restauración en función auditiva vestibular? ¿En dónde estamos parados para esto?
Yeah, good question. So there are two goals of this particular. Not the time you might see a certain amount of reduction in growth, but really the goal is not necessarily reduction in growth, but cessation of growth of small tumors. And the hope is that we would see improvement in hearing. The virus would be delivered into the cochlea and the protein would be produced in the cochlea, although some of the virus may get directly to the tumor through the cochlea. There is no diffusion barrier between the cochlea as well as the internal auditory canal. So there have been some data that has emerged recently where if you inject in non-human primates virus into the third ventricle or lateral ventricle of animals, and you can see that the virus gets into the inner ear and transduces cells within the inner ear. There was also some recent data from Rick Nelson's group showing that if you place gadolinium into the CSF in patients that they were testing for CSF leak, the gadolinium goes from the CSF very efficiently into the cochlea. So there's not much diffusion barrier. So the hope is that high concentrations of the antibody will be produced and diffuse locally to the vestibular schwannoma, which is immediately adjacent to it. We don't have a deep understanding of the mechanisms by which anti-VEGF protein seems to have the benefits that it does on vestibular schwannoma growth and hearing, but we do have the observations from the patients that have neurofibromatosis type 2 that indeed hearing does improve in a large fraction of patients, as well as the tumor growth being halted. And so, although there are a variety of mechanisms to imagine that would be the cause of that, we will determine in the clinical trials whether or not we see those same benefits with the delivery method that we have described.
Muchas gracias.
Tenemos por aquí otra pregunta que nos habla si la terapia estaría indicada solo a pacientes con emisiones presentes. Y esto creo que podemos poner un poco de la mano, es decir, necesitamos que haya algún porcentaje de células presentes, de células sanas, externas o internas o de ambas, o podrá ser que aún con ninguna célula sana pueda tener eficacia la terapia.
So I think for otoferlin, it's highly unlikely that the therapy would be effective if the hair cells are lost already. You would have to probably have a separate therapy that would restore the hair cells, and in addition, provide the otoferlin on top of it. So initially, we will only be going into patients that we think have the greatest likelihood of success, which are those that have very robust otoacoustic emissions. Now, what we don't know is whether or not there might be benefit in patients that don't have otoacoustic emissions, but still have some inner hair cells that are left. So say a patient has presence of cochlear microphonic, but no presence of otoacoustic emissions. I think we don't really know yet. Depending on the results of the initial trials, if we see a very, very strong result in those patients with intact otoacoustic emissions, we can consider moving on to patients where the otoacoustic emissions are either decreased or absent, and see if there might be benefit in those patients as well. But we'll see. I suspect it might not help that much, but we will be guided based upon the clinical data that we see in the trials.
Esto será también parte de la importancia de las técnicas de preservación auditiva en el implante coclear, ¿no? Esto estará de la mano ahí. Y quizá con el tiempo un paciente que esté implantado, pues a lo mejor se le retira el implante y esta terapia puede ser mejor, pero necesitamos que tenga audición residual o preservación de la audición. Una pregunta. De acuerdo han llegado a detectar ustedes que de acuerdo al gen que esté alterado, en alguno de ellos han podido establecer algún patrón del tipo de pérdida auditiva, poder decir, bueno, este tipo de alteración génica tiene este patrón más en graves, más en agudos, ¿lo han logrado establecer?
Yes, so I'll answer the question both for otoferlin as well as for other genes. So with otoferlin in particular, the majority of the time it is a severe to profound, relatively flat sensorineural hearing loss, but there are a small minority of patients that actually have a interesting temperature sensitive mutation where they will have normal hearing until they get a fever. Then when they get a fever, their hearing will drop. And then when the fever resolves, their hearing will come back. Otoferlin itself tends to be reasonably flat. There are different mutations in the gene, but most of them just inactivate the function altogether. For other types of genes, they do tend to have some characteristic hearing loss patterns. Some things tend to be very severe to profound, some are flat, but at higher frequencies. As I mentioned, things like stereocylin, it's more high frequencies than low frequencies, and also relatively flat, and tends to be about 50 decibels, 40, 50, 60 decibels. But it depends on each individual gene. Richard Smith, who is one of the co-founders of our company, has created a website where you can look up different genes and see the profiles based upon data that have been published for different genes, where you can see the progression of hearing loss at different frequencies by age for a variety of different genes that have been reported.
Doctor, hablando de estas pérdidas auditivas relacionadas a la temperatura, a fiebre específicamente, ¿cuál es el pronóstico a largo plazo? Una vez, porque sabemos que el periodo de fiebre es más común en niños, pero si a estos niños se les ha dado seguimiento, ¿cómo les va en la edad adulta cuando realmente ya no están tan expuestos a estos picos febriles? ¿Qué pasa con ellos?
Yeah, this is a good question. So this is a very, very rare condition. Only a few families have been reported that have this. So we don't have spectacular longitudinal data of these people over time. However, a number of the individuals that have the temperature sensitive mutation are older, are adults already. So we presume that their hearing is generally intact, even into older age. And then if they get fevers, say if they get a cold or something like that, it will still decline. But apparently, it is not a harbinger of obligately losing all of the residual hearing at an early age, for example.
Bueno, pues ha sido una noche muy interesante, una noche que nos motiva. Creo que los médicos habitualmente tenemos dos razones para no poder dormir. Cuando tenemos problemas con un paciente, problemas de diagnóstico, problemas de tratamiento, pero también cuando tenemos ilusiones, cuando tenemos esperanzas en que algo puede llegar, y creo que esta noche va a ser así para muchos de nosotros. Hay que recalcar, todavía vi algunas otras preguntas que nos piden o buscan cuál es la utilidad de este tratamiento en patologías, en humanos y en adultos. Hay que insistir, esto ha concluido o ha pasado ya la fase de laboratorio y ahora está con algunas enfermedades en particular buscando su eficacia, ¿no? Y de ahí pues se irá desprendiendo seguramente de manera exponencial para muchas otras enfermedades y veremos en algunas quizá funcione un poco más, quizá en algunas no tanto y lograremos ir sabiendo qué es lo que va a pasar con estos tratamientos y estos pacientes. Doctor Ward, muchas gracias por haber compartido sus conocimientos, su experiencia con nosotros y la invitación que nos ha hecho. Seguramente varios el año siguiente, cuando se abra a pacientes internacionales, pues nos gustaría poder brindarles la oportunidad a esos niños que puedan estar con ustedes. A nombre del Colegio Mexicano de Otología, Neurotología y Cirugía de Base de Cráneo, agradecemos a las doctoras Medrano y Alonso el haber estado con nosotros y al doctor Ward nuevamente el haber estado esta noche. Seguramente estaremos en contacto muy pronto. Muchas gracias a todos los asistentes. Agradecemos a Lilia Castañeda por la gran traducción que siempre nos brinda y nos vemos en nuestra próxima sesión que por motivo del Congreso de la Federación Mexicana de Otorrino, que es a fin de mes, habitualmente nuestras reuniones son el último jueves de mes, y por los días feriados de 1 y 2 de noviembre, nuestra siguiente sesión será el día 9 de noviembre con la participación de un profesor de Colombia. Muchas gracias a todos, muy buenas noches, que estén muy bien.